Welcome to the deep dive. Today, we're tackling a really complex area. We're talking about when tumors get tangled up with major blood vessels, arteries, and veins.
Yeah, and what's, really striking is how the treatment approach has shifted.
Hmm.
Surgeons are definitely being more aggressive now than, say, 20 years back.
Right. And that's probably down to, well, better surgical techniques, wouldn't you say?
Definitely improved techniques, but also, frankly, the lack of other really curative therapies for many of these. Surgery becomes the main hope.
It's a tough spot. You've got the cancer itself, which is already hard, and then this added layer of complexity with the blood vessels.
Exactly. It demands, expertise in both oncology and really specialized vascular surgery.
So to help us navigate this, we're diving into the key chapters from Rutherford's Vascular Surgery and Endovascular Therapy. It's really the definitive text.
It is.
Now, just to set expectations, this isn't light listening. We're doing a focused exploration here, looking at the challenges, the classifications, the treatments for these, well, thankfully rare, but very serious vascular tumors.
Yeah, our goal is to give you a solid grasp without getting totally lost in the weeds.
Think of it like a look behind the curtain at some really high-stakes surgery and decision-making.
Mm-hmm. When do surgeons decide to go in? How do they do it? What are the outcomes usually like? It's pretty incredible how far things have come.
Okay, so let's break it down. Two main categories we need to talk about. First, primary vascular tumors. These actually start in the vessel walls.
Right, originating right there in the artery or vein.
And then the second type, secondary involvement. That's when a tumor starts somewhere else, lung, pancreas, whatever, and then grows into or around the vessels.
And even within those, there are important distinctions. Let's start with primary arterial tumors.
Yeah.
Aortic sarcoma is kind of the main one there.
The aorta, yeah. The body's biggest artery. A tumor there is obviously a huge problem.
Huge problem, and thankfully very rare.
So Rutherford explains how they classify these based on how they look, where they start in the aortic wall.
Yeah, there's Solm's classification. You've got polypoid or intraluminal, which means sort of growing into the channel.
Like a little polyp inside the pipe.
Exactly. Then intimal from the inner lining and adventitial from the outer layer.
Okay. And then Wright simplified it.
A bit, yeah. Wright and colleagues kind of grouped the inward-growing ones, polypoid and intimal, together, and then called the outer wall ones mural.
And why does that origin matter so much?
Well, it dictates how they behave, really. Those polypoid ones, the ones growing inside. They have this nasty habit of breaking off.
Embolizing.
Right, sending little tumor fragments downstream, which can cause blockages, in the legs, arms, even the brain.
Wow. Okay. And the other intimal ones?
They tend to spread more along the inside wall, infiltrating, maybe blocking off the openings to branch arteries.
And the outer adventitial or mural ones?
They grow outwards, they can get quite large, push beyond the aorta itself, invade nearby structures. Also not good.
Yeah, sounds bad all around. The text mentions a study by Stotz et al.
Right, looking at 26 cases of aortic and iliofemoral sarcomas. Abdominal aorta, thoracic aorta, common spots. But the really sobering finding, in none of those cases was the diagnosis suspected beforehand.
None. So they were found incidentally or mistaken for something else.
Exactly. Tells you how rare they are, how they can mimic other things.
And the prognosis.
Generally poor, unfortunately. They tend to metastasize early, often poorly differentiated cells. It leads to pretty low survival rates overall.
It really drives home why surgery, if possible, is often so aggressive. There just aren't many fallback options.
Precisely.
Okay, let's shift gears to secondary arterial involvement. This is the cancer starting somewhere else than hitting the arteries.
Yeah, much more common scenario than primary arterial tumors.
And it can happen with lots of different cancers, right? Head and neck, lung.
Lung, musculoskeletal, colorectal, pancreatic, gynecologic cancers, retroperitoneal sarcomas. Quite a list.
And it's not always malignant tumors either.
No, that's a good point. Rutherford mentions benign tumors like ganglioneuroma, non-cancerous, but they can still grow right around the aorta and its branches, encasing them.
Figure 194.1 shows that, right? A big tumor, but benign, still causing major issues just by being there.
Exactly. It can still compromise blood flow or make surgery incredibly difficult, even if it's not cancer.
So even benign growths need careful handling if they're wrapped around major vessels. Okay, let's move to the veins. Primary venous tumors first.
Okay, so primary tumors of the SVC, superior vena cava, and the peripheral veins are less common than those in the IVC, the inferior vena cava.
And the main player here is venous leiomyosarcoma, PVL.
That's the one. It's the most common primary venous tumor. And interestingly, it's actually more frequent than primary arterial sarcoma.
Huh. And how does it typically grow?
Often polypoid or nodular, usually growing inside the vein lumen. But
There's always a but.
yeah, don't let that fool you. They can be quite aggressive, invade through the vein wall, involve adjacent organs.
And IVC leiomyosarcoma makes up a big chunk of the surgical cases.
About a third, according to the text.
And the prognosis, similar story to aortic sarcoma.
Unfortunately, yes. Often metastasizes early. Poor survival rates overall. Aggressive disease.
Again, highlighting the need for complete removal if you catch it early enough.
That's the goal. Radical resection before it spreads, though often it's already spread by the time it's found.
Okay, now secondary venous involvement. What's the most common scenario there?
For the infrarenal IVC, the part below the kidneys, the retroperitoneal sarcoma, is the most common culprit, invading it directly.
But other cancers can invade the IVC too.
Oh yes, bowel cancer, liver, pancreas, kidney, adrenal cancers. Depending on their location, they can grow into different parts of the IVC.
And then there's this other mechanism, tumor thrombus.
Right. This is different from direct invasion. Here, the cancer grows through the wall of a smaller vein that drains the tumor.
And then extends into the bigger vein, like the IVC or SVC.
Exactly. Like a finger of tumor growing right into the bloodstream, but still attached.
And the classic example is kidney cancer, renal cell carcinoma, RCC.
That's the prime example, yeah. A significant percentage of RCC patients develop tumor thrombus. And it could extend just a little way or, snake all the way up the IVC, sometimes even into the heart. Figure 194.2 shows this.
Wow. That adds a whole other level of complexity to the surgery, doesn't it? Dealing with the kidney tumor and this chunk of tumor inside the main vein.
Massive challenge. Which brings us nicely to how these patients actually show up and how doctors figure out what's going on.
Clinical presentation and evaluation.
Right.
So for aortic sarcomas, what kind of symptoms?
Can be really varied, often misleading. You might get arterial obstruction from those emboli we talked about.
So leg pain, arm problems, maybe even stroke-like symptoms.
Exactly. Or the tumor itself might be mistaken for an aneurysm, a dissection, vasculitis, even just atherosclerosis.
And Rutherford mentions cases where they pop up after endovascular aneurysm repair or near old grafts.
Yeah, which is interesting. You always have to keep these rare things in the back of your mind, even with prior vascular history. And of course, the usual nonspecific cancer symptoms, fatigue, weight loss, just feeling unwell.
Okay. What about the primary venous leiomyosarcoma of the IVC?
More common in women, wide age range, but again, rarely caught early.
Abdominal pain is commonest, but lots of vague stuff too.
Yeah, abdominal pain is the most frequent specific symptom, but many just have those non-specific complaints. And unfortunately, metastases are often present at diagnosis.
And depending on where the tumor is, you might see other effects.
Sure. Cardiac issues, liver outflow obstruction, Budd-Chiari syndrome, kidney problems, nerve or muscle involvement, if it's in a peripheral vein, leg swelling, or DVT signs.
Man, it sounds like getting the diagnosis right is tough. So many mimics, vague symptoms.
It really is, which is why the text hammers home the need for a multidisciplinary team.
Oncologists, vascular surgeons, radiologists.
Absolutely. You need all that expertise together to plan the best course, whether it's surgery or something else.
And the goals of the workup.
Basically, what type of tumor is it? How far has it spread locally? Has it spread distantly? Metastases? And is it blocking blood flow?
And the patient's overall health is key for deciding on surgery.
Crucial. Surgeries generally for localized disease, good organ function, patients who are reasonably active. You have to weigh the risks and benefits carefully.
Okay, imaging. CT and MRI are the mainstays.
Definitely. Essential for seeing the tumor location, extent, checking for mets, planning the operation. You want imaging in both arterial and venous phases. CT venography is often used too.
And MRI is good for telling tumor thrombus from just a regular blood clot.
Yeah, MRI can be really helpful there. And some places use it to predict venous wall invasion, which is important for surgical planning.
Because if the wall is invaded, you might need to replace that section of vein. Studies show residual tumor on the wall is bad news.
Exactly. Increases recurrence risk. So knowing that beforehand is valuable.
What about PT scan?
More selective use. Good for checking distant metastases in various tumors, and sometimes helpful in diagnosing aortic sarcoma.
Ultrasound, echo.
Can be useful for venous tumors, especially key transesophageal echo if CT or MRI isn't totally clear, particularly for thrombus near the heart.
And routine leg ultrasounds for IVC or iliac vein tumors? Why?
To check for silent DVTs, hidden blood clots. Pretty standard practice at centers like Mayo Clinic.
And 3D modeling, you mentioned that helping with planning.
Hugely helpful, especially for complex anatomy. Visualizing the tumor's relationship to vessels, nerves, bones in 3D really aids planning the approach. Figure 194.4 gives an idea.
Okay, and then the medical checkup before surgery.
Standard stuff, but critical here. Heart function, lung function, kidney, liver tests. Assessing overall fitness. If a big liver resection is planned, calculating the future liver remnant volume is vital to avoid liver failure.
Right, so a huge amount of evaluation before even considering the operation.
Absolutely. It has to be thorough.
Okay, so let's say a patient is a candidate. What does the actual treatment, the operation, involve?
Well, the specifics really depend on the tumor type, location, extent, and whether veins are blocked, if there are collaterals. But the first principle is adequate surgical exposure. Getting good access.
Choosing the right incision, the right approach, often a team decision.
Exactly. And that 3D modeling we mentioned. Super helpful for planning access in tricky spots, thoracic inlet, mediastinum, pelvis.
Rutherford's lists various incisions, midline, subcostal, thoracoabdominal, tailored to the tumor.
Yeah, you pick the incision that gives you the best access and control for that specific tumor. Sometimes quite extensive approaches are needed.
Now, can you always separate secondary tumors from vessels?
Sometimes, yes. If imaging shows a clear plane, and even if not perfectly clear, some benign tumors like ganglioneroma or certain germ cell tumors can sometimes be carefully peeled off without needing vascular reconstruction.
But if you do need to repair the vessel,
The ideal is always primary closure, just stitching it up or using a patch as long as you don't narrow the vessel too much.
what kind of patches for arteries?
Prosthetic material or bovine pericardium are common choices.
And if you have to replace a whole segment of artery, aorta, carotid, iliacs,
Usually prosthetic grafts like Dacron or EPTFE, but there's a key exception.
infection risk, near the gut or airway.
Exactly. In those cases, or in frankly contaminated fields, the preference shifts to using the patient's own artery if possible, or a cryopreserved allograft, a donated human artery. They resist infection better.
Sometimes reinforced with fascia lata.
Yeah, buttressing the suture lines. And there's that technique of using the superficial femoral artery from the thigh as a replacement conduit for, say, the carotid or hepatic artery in cancer cases.
Borrowing from Peter to pay Paul, surgically speaking.
Sort of, yeah. You then replace the harvested SFA with a prosthetic graft. It's an option when you need autologous artery.
The text also mentions using aortic stent grafts sometimes for lung cancer invading the aorta.
Right. Placing a stent graft inside first can sometimes facilitate the lung resection without needing to fully clamp the aorta, potentially making it safer.
Okay, what about replacing big veins? Vena cava, innominate, common iliacs.
Large diameter externally supported EPTFE grafts are generally preferred there. The external rings help prevent compression.
But if you're also taking out part of the bowel, infection risk again.
Right. Then alternatives like cryopreserved aortic allografts, or maybe cryopreserved vein, or tubes made from bovine pericardium come into play.
And for the portal vein, the one going to the liver.
Options there include prosthetic grafts, or using veins like the left renal, jugular, femoral, or a spiral saphenous vein graft.
What about just patching a big vein like the IVC instead of replacing it?
That's often preferred if the tumor only involves part of the circumference, maybe up to 60% over a short length. A patch venoplasty, often using bovine pericardium, can work well. Figure 194.5 shows the calculation for sizing the patch.
Makes sense. Preserve native tissue if you can, and for smaller peripheral arteries or veins in the limbs.
Similar choices. Prosthetic, saphenous vein used straight, spirally cut, or paneled or cryopreserved vessels. Depends on size, length needed, availability of the patient's own vein. If you need both artery and vein repair, fixing the vein is often prioritized.
And sometimes if a big vein has been blocked for ages and collaterals are good, you might not need to replace it at all.
Correct. If the body has already found good detours and you can preserve those during the tumor removal, reconstruction might not be necessary. Temporary shunts can also be used during big limb tumor resections.
Okay, let's dig into IVC replacement specifically. It sounds particularly tough. Mayo Clinic has criteria for when to do it.
Yeah, generally if you need to resect most of the circumference for clear margins and the vein isn't already completely blocked with good collaterals.
And they often use 16 or 20 millimeter EPTFE grafts.
That's common, yeah. Good patency rates reported. Size can be a limitation sometimes. And again, if bowel resection is involved, alternatives like cryopreserved aorta or vein panels are considered.
UCLA uses smaller grafts. Why?
The theory is that smaller diameter might mean faster blood flow, potentially improving long-term patency. It's a point of discussion. Important thing with EPTFE is placing those external rings near the connections.
Right, to prevent kinking or narrowing. Is infrarenal IVC replacement the easier end?
Relatively speaking, yes. The main challenges are controlling the iliac vein inflow and dealing with bleeding from those tricky lumbar and sacral veins back there. Their anatomy can be quite variable.
And creating AV fistulas isn't really done anymore.
No, largely abandoned. Post-op anticoagulation seems sufficient for patency in most cases.
What about near the kidneys, the perirenal IVC?
If you resect that segment, especially if you also take the right kidney, you really want to reconstruct or reimplant the remaining renal veins, particularly the left, to avoid kidney failure.
Okay, now the really complex part. Retrohepatic or suprahepatic IVC behind or above the liver needs special techniques.
Oh yeah. Often requires total vascular isolation, TVI, where you temporarily stop inflow and outflow to the liver. Sometimes venovenous bypass or even full cardiopulmonary bypass is needed.
To keep blood circulating while the liver supply is clamped.
Exactly. Careful clamp placement, ischemic preconditioning of the liver are also key, especially with major liver resection.
Rutherford's details the steps for TVI and resection, clamping order, managing blood pressure.
It's a very choreographed procedure. Sewing the graft high up near the hepatic veins is challenging. PTFE is stiff, the native vein can be fragile. Parachute technique can help. Getting the graft length just right is crucial too.
And if the tumor actually blocks the liver veins?
That might require cardiopulmonary bypass and cooling the patient. Then you can mobilize the liver, open the atrium perhaps, resect the IVC and tumor, taking the hepatic vein openings as a button, and then reimplant that button onto the new IVC graft. Very complex. Alignment and stopping bleeding are major hurdles.
And the alternative is taking the liver out entirely, ex situ resection.
That's an option for extremely complex cases where you anticipate very long ischemia time otherwise. But it comes with even higher risks, reserved for very select situations.
Phew. Okay. After all that incredible surgical effort, what are the outcomes? What does the data show?
Well, it's variable. Depends on patient factors, tumor factors, the type of vascular repair.
For the rare primary arterial cancers,
Data is limited due to rarity. Mayo Clinic's angiosarcoma series showed high rates of metastasis at diagnosis, poor overall survival, even with surgery.
another series by Carpenter also looked at aorta major artery tumors.
Found iliac artery involvement was common, sarcoma most frequent. Aortic resection had some mortality and graft issues, but was feasible. A pooled analysis also showed poor overall survival generally, but suggested surgery plus adjuvant therapy might help slightly.
What about locally advanced pancreatic cancer involving vessels?
There's that increasing trend of en-bloc resection, including the celiac axis, after neoadjuvant chemo. Mayo series showed it's feasible, high revascularization rates, but significant morbidity mortality, though improving. They say consider it in select patients at specialized centers.
Okay, outcomes for IVC malignancies. Hard to compare studies.
Very hard. Different tumor types, lumping primary closure with grafts. Location matters too. Retrohepatic, generally tougher than infrenal. Older series had higher mortality.
But more recent series are better.
Yeah, contemporary series from Quinones Baldrich, Hemming, Globova, and others show impressively low mortality now, despite the complexity. 5-year survival is hitting around 50% in some reports for primary-secondary IVC tumors.
Mayo's series on segmental IVC resection with grafts
Showed decent overall and disease-free survival rates, supporting the aggressive approach, but again highlighting the need for better adjuvant therapies.
and for kidney cancer with tumor thrombus in the IVC.
Surgery definitely provides the greatest survival benefit there. 5-year survival varies, depends on negative prognostic factors like sarcomatoid features, positive nodes, residual tumor on the Keval wall.
And the vascular margin status is key.
Seems more important than just how high the thrombus went. Getting clear margins on the vein wall is critical for survival.
What if you do liver resection and IVC reconstruction together?
Add significant complexity and risk. But studies, like Sarmiento's and Hemming's, show it can be done with acceptable mortality in experienced hands, and long-term survival is possible for select patients, supporting an aggressive approach for liver tumors involving the IVC.
But adjuvant therapies are still lagging behind.
For many of these IVC tumors, yes, tyrosine kinase inhibitors help in RCC, but less impact on the thrombus aspect. Radiation might have a role for local control in some sarcomas, maybe proton beam pre-op, Still evolving.
Okay, quickly, superior vena cava obstruction, mostly lung cancer.
Yeah, lung cancer or mediastinal nodes are most common causes, often treated palliatively with stents. But if it's localized disease needing resection, EPTFE grafts are used for SV-synominate reconstruction.
And peripheral vein reconstruction for cancer, less common.
Much rarer than IVC work. But series like Mayo's show good early results using various grafts, prosthetic, vein, cryo. Long-term patency can be challenging, especially with prosthetics, but feasible.
Okay, so let's try and summarize this deep dive. It's clear that surgery for these vascular tumors has become way more aggressive, more sophisticated.
Absolutely. Driven by better techniques, better understanding, but also the, lack of other great options often.
And the multidisciplinary team approach is just essential. Careful patient selection, too.
Absolutely critical. These are huge operations. You have to pick the right patient, the right tumor, the right time. The outcomes are getting better, but still variable.
And while surgery offers a real chance, there's still that big need for better adjuvant therapies, right? To improve long-term survival, stop recurrence.
Definitely. That's where a lot of future progress needs to come from.
So maybe a final thought for our listeners. Given how complex these surgeries are, the risks involved, the variable outcomes, what are the sort of ethical considerations when offering these really aggressive interventions for these rare, often aggressive cancers?
That's a really important question. Balancing that potential benefit against the significant risks and burdens of treatment. It's something surgeons and patients grapple with constantly. Definitely something to reflect on.
Indeed. Well, thanks for joining us for this deep dive.